Okay, it's very difficult to squeeze the entire CVJ in childhood into 15 minutes, but I just really thought I'd try and give a little bit of an overview and highlight through some conditions, some, I think an algorithm by which one can try and simplify the craniovertebral junction first of all, because I think, that complexity that you've just heard about, I don't think has to be as bad as it is sometimes perceived. We then, I think, need to have a strategy, an algorithm, if you like, for how to investigate and manage these children. And then I think the tactics, which is different to the strategy. The tactics are then how we implement the strategy. And I think that can be quite specific in certain conditions. And I'm going to mention a few of them, particularly Downs, Morquio and achondroplasia. I think one of the problems that Dr. Menon referred to is the sheer breadth of disorders in the pediatric age group where craniovertebral junction anomalies can happen. If you look on OMIM, the online Mendelian inheritance in man, there's well over 200 recognized genetic conditions where the CVJ is involved. And of course, and these are just some of the ones that I've seen in my practice. And of course, how you classify these is extremely variable. We can do it by a developmental mechanism. The metabolic physicians will have their own classification. The geneticists now, who can identify many of the underlying single gene disorders, will have their own classification. But none of these really actually satisfy our requirements in the surgical clinic. And I over time, because I've been often faced with somebody coming in with Melnick needles type 1 and I haven't got a bloody clue what that is, but so there's a question that you have to then, I think, adapt what one knows from other conditions and try and make an algorithm that one can apply more widely. And in essence, I guess like with any other, even in adult the situation, there are really only three things that ever happen at the pediatric craniovertebral junction. They're either unstable, they're deformed, or they have neuraxial compression. And of course, one gets clear, if you like, pure examples of each of these. Instability is the real classic problem in the Down syndrome trials. They're hypermobile with a risk of underlying problems. Many of the children who have these underlying disorders of segmentation, some of these PAX and HOX type mutations, give these bizarre segmentation anomalies with deformity. And then you've got instances where really the primary problem is simply compression and nothing else. And a good example of that is achondroplasia. They're not unstable, they're not deformed, they're just very, very tight. And of course, each of these has the potential to cause neurological disability. And of course, each of them can happen in combination. In fact, it's very rare that you see pure instability, pure deformity, or pure compression. So for example, in the Morquio, yes, you will have a combination of hypermobility due to their rather poor ligamentous structure, the infiltration with all the glycosaminoglycans, and associated with compression. Or in this example, this is Hadju-Cheney syndrome, which is something a little bit like osteogenesis imperfecta. You get this very dramatic soft tissue softening with a combination here, as you can see, of significant skull-based deformity with compression. But as I say, each of these, whenever one sees them, whenever I see a new patient with whatever syndrome, and I tell the patients, what I'm looking for: have you got instability? Have you got deformity? Do you have neuraxial compression? If the answer is no to each of those, see you in a couple of years. But if there's a worry about them, then how do I investigate that? Clearly, with instability, one wants usually some form of dynamic imaging. There's a bit of a vogue out there in some of the groups talking about the role of dynamic MRI and so forth. The sensitivity of actually dynamic MRI is very, very poorly understood at the moment. We don't have good normative data, and still probably the best investigation for you to investigate instability with is the dynamic flexion extension X-ray. That will give you a good idea of range of movement. You get much greater range of excursion than you would do in an MRI or CT scanner. Furthermore, MRI, CT, particularly in the young kids, they need an anesthetic, and clearly you don't want to be doing dynamic imaging for those. If one's wanting to look at deformity, yes, of course, then fine cut CT, much, much better. X-rays, very unhelpful in the craniovertebral junction in children when one's trying to look at deformity. And obviously, as neurosurgeons, one's often wanting to look at what the effect of these abnormalities is on the neuraxis, and obviously for those one needs an MRI scan. And then clearly on the basis of whichever of these we find, then clearly that now starts to give rise to, or to, if you like, define our strategy of management. And I think as neurosurgeons, we've tended to, I guess, be more worried certainly about the compression side of things, and then we throw it on, we're going to make it unstable, so then we do about the fixation. I think neurosurgeons are terribly bad at remembering the third component of the trinity, and that being the issue of deformity. And I think many, particularly in children, many of these complex abnormalities, you can significantly improve that deformity, which may obviate the need for decompression as well as fixation. So it's worth, I think, trying to apply those principles to some of the more common conditions that one sees. And as you know, Down syndrome, clearly this is a group that have caused a lot of concern to medical groups over the years. As I said to you earlier, their main problem is that of instability. They get an atlantoaxial instability. It tends to occur in the sagittal plane. The difficulty is really knowing, how do we actually define when is a child at risk when they've got hypermobility? C1, C2 is designed to move, but when is it moving too much? And that, by definition, which ones require surgery? And actually, you know, in the books, you'll look at every textbook and they'll say, oh, you just measure the atlantodental interval. And if that's too high, they need a fixation. If it's not. But actually, let's look at that. It's a terribly unhelpful measure. Yeah, typically, this is what we're looking at. Occasionally, some people will use the posterior atlantodental interval or the neural canal width, the space available for the spinal cord. Yeah, but actually, I'm going to tell you why actually it's not such a great measure to use in Down's children. And that's partly, do we have a definition of it? Yeah, do we know what the natural history of it is? Is it actually even reproducible? If you look through some quite old data now, if you look, most of the publications take an atlantodental interval. It's quite variable. There's no agreed definition. It can be anything from 4 to 5.5. I've seen even up to 7 millimeters in some publications. So clearly, the first thing is the criteria by which we measure atlantodental interval. That's not even agreed. And in fact, the numbers that are there in most publications are probably way too low. So the result is you will significantly overestimate the incidence of instability. And I think as a result, people have said that atlantoaxial subluxation you'll see occurs in 30% of Down's children. That it probably does if you have a measure of around 4 to 5 millimeters. But clearly not 30 to 40% of Down's children ever require an operation. How predictive is it? Yeah. So these are those same studies. In green, I've got cases that went on to develop instability. Those that those that did not develop instability are in green. The ones that did are in red. And you can see in the majority of cases, yeah, even where children exceeded these norms, yeah, the majority actually didn't over time, because these are forward sequential studies, develop instability. So it wasn't really a very good predictor of natural history. Furthermore, what actually about even if you do measure subluxation and its correlation with symptoms in the child? Yeah? In this study, a large number had subluxation, but actually the majority of those had no clinical symptoms at all. By contrast, there was a non-subluxing group, again, large group, yeah, in whom there were some children that had symptoms and signs compatible with a myelopathy. Yeah? And so clearly, yeah, again, our use of atlantodental interval as a judgment of who we should operate on is very poor. And what about the problem of reproducibility? This is a nice study which you could never do now, because they took Down's children, 6 of them, they did a flexion extension x-ray in the morning, yeah, and they repeated it in the afternoon. And you can see here that actually it then changes even in the course of the day. You know, this child in the morning, yeah, he would have been having an operation, but he wouldn't have been in the afternoon, yeah. And similarly the other way round. Yeah, you've got a kid who's fine in the morning and who's not in the afternoon. So it's not a reproducible test. And so a few years ago, with the British Downs Medical Group, we got together, in fact, with the British Paralympic Committee, because they've got some excellent data on children with Down syndrome who go on and do all sorts of crazy sports, diving, gymnastics and all the rest of it. And they are very lax, actually. I was very surprised. I thought they'd be more restrictive. But they go very much on clinical. And so now we don't recommend screening for children with Down syndrome because it's non-predictive, but actually very much it's on question of parent and carer education that any of these red flag symptoms or signs should then prompt referral for investigation. And at that point, it's going to require detailed neurological examination and tests that might include flexion extension x-rays, but probably, certainly if you have any of these, MRI scan. The problem with Downs is that the high-risk ones, when you do filter them out, the ones that end up with symptoms are not actually those just with instability. They've often got this associated ossodontoidium. And that certainly is a red flag when it's seen in the combination of symptoms, because it leads to an incompetence of the transverse ligament. You get severe hypermobility, and these children, without question, need fixing, and they need fixing quite soon. As I said at the beginning, the importance of reduction. I've got a series now of about 40 or 50 transoral operations in children. The commonest reason for me have to do a transoral odontoidectomy these days is a child that somebody has tried to fix with Down syndrome who hasn't been appropriately reduced at the beginning. And these children end up with their odontoid peg sticking in the front of the spinal cord like this. They're then fixed at the back, they're worse neurologically post-operatively, and your only option is then to go in the front and take out the odontoid. What about Morchio? Here we've got a different situation, because now we've got a problem of ligaments and bones, the combination of instability and neuraxial compression. It's very rare. As you well know, there's disease-modifying drugs now in the form of enzyme replacement therapy, but unfortunately those don't have any impact on the neuraxial disease. Many of these children will develop either acute or chronic myelopathy, and indeed acute myelopathy in these is much more common than, for example, in Down syndrome. And in fact, we looked in a recent publication, this was from last year, we looked at the natural history of instability and craniocervical compression in Morchio children. And you'll see, this is from our series at Great Ormond Street. The first thing is to say you are much more likely to end up with myelopathy and require surgery at your craniovertebral junction if you have Morchio than, for example, in Down syndrome. In Down syndrome, it's about 1 to 2% of the entire population. Here, the majority of children at some stage will end up with surgery. Furthermore, they're requiring that surgery quite early. Many of the children were requiring operations before the age of 5. And of course, then you have a problem because you've got a significant bone dysplasia in a very young child, often with comorbidities, and some limitation to what's available to you in the form of instrumentation and fixation. Again, MRI is your best screening test here. Interpreting X-rays, flexion extension X-rays in the young Morchio child can be very difficult because the bones are so immature, often significant ligamentous problems, which clearly you won't identify on the CT, on the X-rays, but clearly on MR you can see that combination of ligamentous and bony thickening causing a significant signal change within the spinal cord. Clearly, the gold standard is instrumental fixation when you can do it, but obviously the technique is somewhat age dependent, because clearly a 2-year-old Morchio may be very difficult to internally fix, whereas at the age of 5, 6, 7 that becomes much greater an option. But again, reduction absolutely paramount. Then, if after optimal reduction you've still got some compression there, then you can decompress at the time of your stabilization procedure. How does one fix? Clearly, there are a number of techniques available to you. All the repertoire in the adult world is not necessarily applicable to the children. And in the very young ones, you may simply not have the bone stock that'll take a 3.5mm screw. And so, still, in the young children, in the under ones, the infants, or even up to sort of 3 or 4 with bone dysplasias, full thickness calvarial graft can be extremely effective. You can get a very nice fusion. You do need to immobilize them post-operatively. But of course, in the older ones, or where the anatomy is favorable, obviously fixation is clearly the gold standard. Finally, achondroplasia, here you have a problem primarily of bone and compression. This has become very topical at the moment. There are now on the market, or coming rapidly onto the market, some now phase 3 trials of disease-modifying drugs for achondroplasia. The achondroplastic population do not want to be made bigger. In fact, they find it an insult that the medical profession want to make them bigger. But if these diseases can change the thoracolumbar junction in achondroplasia, or it can change the dimensions of the foramen magnum, that from a medical point of view, I think is very worthwhile. There's no doubt that children with achondroplasia have a high incidence of sudden infant death, and that a large proportion of that has been attributed to occult compression at the foramen magnum. Many of them end up with chronic myelopathy, and the question is, should you screen them? Yeah, and in fact, I was having a big debate in Salzburg last weekend where I had a big meeting about this, and the jury is very much out. This consensus statement came out from a publication from the US a couple of years ago now, and it came out with this statement: foramen magnum decompression is appropriate in the presence of signal change. Yeah, but actually they also concluded surveillance, population-based imaging for infants with achondroplasia is not recommended. The difficulty with that statement is, again, if you look at our series, for example, yeah, you look at children who've got neuraxial compression as demonstrated on MRI scan, yeah, but the number that actually have symptoms is actually very small. Picking up myelopathy, yeah, in a 15-month-old with achondroplasia can be extremely difficult, yeah, and so you genuinely cannot rely just on clinical signs, and many of them will end up with these problems in the craniovertebral junction. Yes, that can cause sudden problems, but also what effect does it have on them a long time? You know, these are the ones that those rather stiff, poorly mobile achondroplastics, could they have been made better by dealing with this earlier? The policy we now have in London, we've developed this grading system for kiddies with achondroplasia. We do try and get an MRI scan within the first year to 18 months in all children, and it's really the higher grade ones looking at. Why? Because actually high grade stenosis, yeah, many of these entirely normal clinical examination. And so, you know, those are the ones that we're wanting to pick up before clearly they end up with a problem. They don't need fixation, they just need decompression. It's very, very rare to have an achondroplasia patient with instability. But the anatomy is challenging. You know, the width of the foramen magnum is in the region of 12, 13 millimeters, and though the vertebral arteries are often much closer, and one so has to be quite careful of the decompression there. There's this phenomenon of complex Chiari. Failures of Chiari type 1 malformation are not insignificant. Yeah, and really, again, yeah, I'm always a bit beware of radiologists with rulers, but nonetheless, sometimes it is actually worthwhile assessing the craniovertebral alignment before thinking about Chiari 1 decompressions. And it's now become much more, I think, prevalent in neurosurgical communities that we're aware of this concept of the so-called complex Chiari patient who's going to do badly if you just do a foramen magnum decompression alone. And again, it comes back to this issue of reduction, reduction, reduction. If you decompress clearly somebody who's abnormally configured at the craniovertebral junction, your risk of late deformity, of worsening neurology is much greater. Clearly, you can get very severe forms like this. This child had a Chiari. And again, in the children, you can't assume something like this is going to be irreducible, even if it doesn't look much better on extension X-rays. They often require some traction intraoperatively to pull that out with monitoring, yeah, and one can often improve the alignment significantly to allow you then to go on, improve that position of that odontoid peg, remove the tonsillar compression from within the spinal cord. And here's an example here. It doesn't actually look that bad on the MRI scan, but one does have descent of the obex, and what this so-called this grab line, which gives you an idea of how much the odontoid is compromising the cervicomedullary junction, gives you an idea of the ones that would probably benefit from some preemptive traction to pull that odontoid down, and fix concomitantly. And there you can actually treat the effect of the decompression. So the syrinx there, as you can see, better, having reduced that deformity. So really, just going back to what I said at the beginning, and I've obviously just chosen a few of the more common bone dysplasias and abnormalities to exemplify what I think is a probably more pragmatic approach to the craniovertebral junction in children. Yes, asking these three questions. Is this child unstable? Yeah. Do they have a progressive deformity? Do they have neuraxial compression? Because that will basically give an idea as to what actually one needs to do surgically. Define the pathological mechanism, always consider reduction in the first instance, only decompress when you've optimized reduction, and then stabilize. And I think this will give some idea as to those who should screen and how they should be treated. The Ehlers-Danlos type 3, if anybody wants to get into that argument, very, very happy to have it. But as I say, I don't know if you have come across those yet. They're a big problem at the moment. So I'm going to leave it there. So thanks very much.
Thank you, Dr. Thompson. Since each of them are discrete topics, I think we should take questions at this time. Are you happy to answer the questions, Dr. Thompson? Any questions from the audience?
Dr. Thompson, elegant lecture, very, very enlightening. Thank you. I had a question in the complex Chiari. If the compression is not that impressive, but there's a lot of syrinx down below, like in the case that you showed, would you preemptively go and decompress even if he didn't have symptoms, or he just was hyperreflexic?
So your question is the Chiari 1 malformation with a syringomyelia?
Yeah, but insignificant visual compression.
Yeah, and well, again, actually, I think it's one looks at that clivoaxial angle. Is the overall craniovertebral alignment within normal limits? And if so, then a posterior decompression will remain the mainstay of treatment for that group of patients. But there is no doubt, a proportion of children undergoing Chiari surgery don't necessarily have great outcomes. They come back with either a persisting syrinx, ongoing and progressive scoliosis, and in those, could one have made things better by, addressing that first of all and getting so it's those really where you get that anterior compression of the odontoid, you get translocation of the odontoid peg, and the obex being lower than normal. That combination of those three factors is telling you beware just going with a posterior decompression.
Any further questions? Okay, we move on to syndromic deformities.